This is really a shocking statistic, but the #1 killer of Americans under the age of 50 is now drug overdoses.
And deaths are rising faster than ever because of the opioid crisis. Joining us now to talk about this problem, Dr. Sharif Zafran, president of the Texas Medical Board. Good morning.
Morning,
Good
Sarah.
to see you. You and I were just talking about this 2,800 deaths here in Texas per month. I think that number would shock anyone. How did we get here?
Well, this really goes back to the mid-1990s, where pain became the fifth vital sign, so to speak, by the Joint Commission. And from that standpoint, physicians were encouraged to make sure that patient satisfaction around that fifth vital sign was met. Around that time, drug manufacturers started encouraging the use of certain narcotics. It's interesting, Purdue Pharma is one of those manufacturers. They're now under a lawsuit by the Attorney General, but they were the manufacturers of OxyContin. And that usage, right after the fifth vital sign was implemented, started to increase the amount of usage of that drug. That kind of fast forwarded to right now, where these drugs and these opioids, where they've been used and prescribed to patients, have led to addiction. They've also led to the usage of patients using them out on the street, not just patients, but other addicts also. Add on to that the fact that we've got synthetic narcotics being shipped from overseas, smuggled in. Fentanyl, synthetic fentanyl is a big problem that we've been seeing with that.
So it's coming from different directions.
It is, and what they've been doing is they're mixing it with heroin and making it even more toxic. And the problem is that heroin, along with synthetic fentanyl, it's hard to kind of gauge, where the toxic amount is going to be, and then they die from it.
But what's the alternative for the people that truly are dealing with chronic pain? What do they do? They're the ones that are kind of stuck in the middle of all this.
So one of the things that we have to be careful of is to make sure that opioids are prescribed appropriately, and where we can to minimize the use of opioids, even in chronic pain patients. The Texas Medical Board has put out a lot of rules based on legislation that's been passed by the state, where we give specific parameters around where physicians can prescribe opioids. For example, in hospice care, in cancer patients, there is no limit as to, there's little restriction as to how opioids can be prescribed by physicians. But beyond that, we encourage the use of non-opioids for treatment of pain. When opioids are used, it has to be done under strict parameters, making sure that drug screens are done, that a contract between the patient and the physician is signed, agreeing to make sure that strict oversight is being done between the physician and the patient. And we as a medical board encourage these rules to be followed to minimize the chance of abuse.
Now, I know you just returned from D.C. You were appointed to the HHS, Interagency Opioid Task Force.
Correct.
What are some of the things that you guys are talking about, a solution to this problem? It looks like it's just getting worse at this point.
Well, Congress is looking at several solutions in general. The President, of course, has made this a national priority. We're looking at alternatives to opioids in the emergency room, in the perioperative setting around the time period that people have surgery. One interesting fact, Sarah, is that 9 to 11% of patients who go through surgery and are started on opioids they're opioid naive. In other words, they've never had opioids before. A year later are still on opioids for no other reason. So there's an amount of addiction that's out there that starts from going through appropriate measures, and what we can do to try to minimize that is important. Congress is looking at that. Our HHS Interagency Task Force is looking at gaps in some of these measures so that we can make recommendations to Congress by next year for laws to be passed to try to help address that.
I was looking at a graph this morning, and I think it went back to 99, and it was relatively level, slight increase. We got to about 2006,
Yep.
and it absolutely skyrocketed. I'm sorry, 2013, it skyrocketed. Why at that point was there such a dramatic jump?
Well, again, this started back in the late 90s, and you can just look at that slow creep of it rising up, and then it exploded after that. But really, when you start looking at the use of synthetic fentanyl, fentanyl we use in the operating room and in other instances appropriately, but this synthetic fentanyl coming from China is about 100 times more potent than regular fentanyl. Mix that in with heroin, and a small amount of it will kill you.
Let's talk about doctors. What can they do? Should they be prescribing less and less of these medications?
So we're encouraging physicians to look at what we call multimodal approach to treating pain, which means that you use other medications that are not narcotics, not to avoid necessarily the use of narcotics, but to minimize the amount that's used. Some of the surgeries that we're going through right now, they're called opioid-sparing surgeries. We have these programs called Enhanced Recovery After Surgery, where we can use minimal amounts of narcotics. Teaching our physicians how to do these things is something that we are focusing on. Incentivizing physicians, educating patients to ask for that when they go and have surgery are some of the measures that we're utilizing. We're also asking physicians to look at their, well, it's mandated now to look at what's called the prescription PMP, which they can look and see and make sure that opioids are not being prescribed by other physicians before they actually prescribe it themselves.
So it's really a community effort at this
It
point.
is.
Yeah. Okay, Dr. Zafran, thank you so much for being here with us this morning.
Great, thank you very much.
All right, we're going to take a break. We'll be right back.